Pediatric upper respiratory tract infections by دعاء هيبه. النهارده هنتكلم على pediatric upper respiratory tract infections. The pediatric respiratory infections are the most frequent infections of childhood. The preschool child has an average of 6 to 8 respiratory infection episodes per year. However, they are mostly of limited self-timing illness of the upper respiratory tract. Risk factor for respiratory infections. Prenatal smoking, especially the maternal smoking, poor socioeconomic status, overcrowding, house conditions, poor nutrition, underlying lung diseases such as bronchopulmonary dysplasia or cystic fibrosis or bronchial asthma. Male gender is more prone for respiratory infection than the female gender. Hemodynamically significant congenital heart disease. Also, the younger the child, the most prone to respiratory infections. Older siblings attending nursery school tend to transmit infections to their household contacts. As for the upper respiratory tract, the most common cause of cough is due to upper respiratory conditions. The average healthy infant is prone for upper respiratory infections up to 8 times per year. The preschool child is prone up to 12 times in relation to only 2 times in the adult population. The pediatric upper respiratory tract infection embraces different diseases, namely common cold, sore throat, sinusitis, and acute otitis media. As for the common cold, short, mild, and usually self-limiting illness. Children may have up to 12 times per year. There are 200 types of viruses responsible for pediatric upper respiratory tract infection, mostly rhinovirus, coronavirus, and the respiratory syncytial virus. The clinical features of the common cold are simple: only rhinorrhea, sore throat, low-grade fever, and malaise lasting up to 7 days. Infant cold may be some troublesome, causing sniffling, difficulty in breastfeeding because of their blocked nose. Cough sometimes may be troublesome. The common cold problem ends that it might end by asthma, or the fever may hike up to causing the severe febrile convulsions. As for treatment of common cold, there is no specific treatment for common cold, only to advise the parents that colds are self-limited diseases and have no specific curative treatment. The fever may be treated using paracetamol or ibuprofen. Antibiotics are of no use in the common cold, since most of cases of common cold are caused by viral infections and secondary bacterial infection is uncommon. However, cough associated with a single infective episode may last from days to weeks. You should put this in mind, that a child with common cold can cough up to 1 to 3 weeks following the attack of common cold. It's also reported that 10% of children may continue coughing up to 4 weeks following the common cold. The second upper respiratory tract infection is pharyngitis. The etiology of pharyngitis, the most important, might be a viral or bacterial. The most serious bacterial infection of the pharyngitis is the group Streptococcal pyogenes, since it can cause rheumatic fever or precipitate in post-streptococcal glomerulonephritis. It also can be presented in the severe form of scarlet fever. In cases of bacterial infections of the pharyngitis, group A beta hemolytic is the most important and the most common. It commonly presented in children above the age of 5. Fever, dry throat, cervical lymphadenopathy, dysphagia are the commonest presentation. The tonsils and the pharyngeal mucosa are erythematous and may be covered by exudate. The tongue may also become red in the form of strawberry tongue. The sequelae might be serious, as it might be complicated by rheumatic fever or post-streptococcal glomerulonephritis, as I mentioned before. Here, this is an important note. In reality, it is very difficult to differentiate between viral and bacterial causes of pharyngitis. However, When marked constitutional disturbance such as headache, apathy, and abdominal pain, while tonsillar exudate and tender cervical lymphadenopathy, the bacterial infection is the commonest. Here's a picture, two pictures showing you the appearance of follicular tonsillitis on clinical examination. Follicular tonsillitis is caused mainly by beta hemolytic streptococcal infection. As you can see, there are follicles of pus covering the palatine tonsils with erythematous wall of the pharyngeal wall, and the tonsils appear red and erythematous. Beta hemolytic streptococcal infection also may result in what's called scarlet fever. And here we will have a child with follicular tonsillitis associated with fiery red cheeks, as it appears in the picture, spraying the area around the mouth with circumoral pallor, sandpaper-like maculopapular rash, and the tongue might be coated with a white membrane or a red inflamed tongue, what's called a white strawberry tongue or red strawberry tongue. As for treatment of bacterial pharyngitis, penicillin V or long-acting penicillin can be given, or you can give erythromycin for children who are sensitive to the use of penicillin. Sometimes in severe cases, children may require hospital admission for intravenous fluid administration and analgesia if they are unable to swallow solids or liquids. Third upper respiratory tract infection we are going to discuss today is otitis media. Otitis media is the commonest second presentation in the ER department for the respiratory tract infection. It is, of course, as the name mentions, it is acute inflammation of the middle ear. It's important to mention that 30 to 60% of children have had at least one episode of acute otitis media in the first year. Up to 20% may have up to 3 times or more. By the end of the third year, 80% of the child population will have at least one episode of acute otitis media. Here's the appearance of a healthy tympanic membrane. As you can see, the tympanic membranes appear shiny, pale, reflecting the light very well, with no appearance of any fluid behind the tympanic membrane. Organisms can reach the middle ear cavity by either reflux from the nasopharynx, particularly if the drum is perforated, aspiration due to high negative pressure, or insufflation through severe crying, nose blowing, sneezing, or swallowing. Pathophysiology of the otitis media: the healthy Eustachian tube is closed, narrow, and drains fluids from the middle ear to the nasopharyngeal area. This photo shows you the difference between the Eustachian tube in adults and in infants. As you can see, in infants, it is wide, it is short, and it is more horizontal than the adult Eustachian tube. And this makes the middle ear in infants more prone for otitis media than the adult. As for types of otitis media, we have acute otitis media. It implies rapid onset of the disease associated with one or more of the following: irritability, vigorous crying, rolling of the head, and rubbing of the ear. This is for infants. Versus otalgia, fever, otorrhea, a recent onset of anorexia, vomiting, and diarrhea in older children. Acute otitis media symptoms are accompanied by abnormal otoscopic finding. Here the membrane appears opaque, bulging, erythematous, and you might even find fluid behind the tympanic membrane. Whereas otitis media with effusion, it's the middle ear effusion of any duration that lacks the association and signs of acute infection. There is middle ear manifestations without fever. As for chronic otitis media, it's a chronic inflammation of the middle ear that persists at least for more than 6 weeks. And here's the appearance of the otitis media in case of effusion, as the fluid appears behind the tympanic membrane. And here's the tube we use, gourmet tube that we use for insertion in the tympanic membrane in causes of chronic otitis media with effusion. As for treatment of acute otitis media, anti-inflammatory analgesia is the main concern in the treatment, as it should be given at regular basis in the first 7 days till the inflammation subsides. Antibiotics are also prescribed, but it is wise to advise the parents to wait for at least 2 days before prescribing giving the antibiotic for children above the age of 2. Complications of otitis media can be extracranial complications, mostly hearing loss and mastoiditis. There might be adhesive otitis, facial palsy, or perforation, while intracranial complications can be in the form of meningitis and sinus thrombophlebitis. For the last most important upper respiratory tract infection, we will discuss sinusitis. Sinusitis simply is worsening of a cold beyond the 7 days of treatment. Most rhinoviral infections improve within the 7-10 days of the complaint. When the complaint persists for more than 10 days with the persistent rhinorrhea and coughing, sinusitis should be suspected. There might be swelling and tenderness over the cheeks, because the maxillary sinuses are usually the sinuses involved in the pediatric population. The frontal sinuses are developed later in life after the first decade. Treatment of sinusitis through prescribing antibiotics and analgesics for the treatment of sinusitis. Here we come to the debate of tonsillectomy and adenoidectomy, the most common operation performed in the pediatric population. Many children have large tonsils, but this itself is not an indication for tonsillectomy, as they think a spontaneous regression might appear later in childhood. So the indication of tonsillectomy are controversial and must be balanced against the risks of the surgery that include recurrent severe tonsillitis, and the guidelines now state that this is at least 6 times per year, or 5 times 2 successive years, or 3 times in 3 consecutive years. Peritonsillar abscess, and this is an absolute indication for the surgery. Also the obstructive sleep apnea. As for adenoidectomy, it is important to know that adenoids increase in size until about the age of 8 years and then gradually regress. In young children, the adenoids grow proportionately faster than the growth of the airway, and this affects narrowing of the upper airway. However, this does not necessitate removal of the adenoids early in life. We should wait. So what is the absolute indication for adenoidectomy? The absolute indication for adenoidectomy is recurrent otitis media with effusion and with associating hearing loss, where it gives a significant long-term additional benefit, especially if reinsertion of Gormley tubes is considered. Another absolute indication for the operation is in cases of obstructive sleep apnea. And by this we finish the lecture of upper respiratory tract infection, and thank you.